So why did we think that we needed to go into a risk situation? Mainly because the only way to manage to be able to save money is to manage the entire dollar. That means that we have to understand where all the risks are and all the gaps in care are. There's the only one that can manage the total cost of care is the physician. It's the physician's pen that determines everything, but it's a very small part of the total cost. So being able to first identify those patients that are risky, being able to create a red, green, yellow or a system that allows you to see who you should be focusing on was the first step. And then from there, having nurses that were able to interact directly with the physicians so that they could communicate on the risks that they were seeing and validate that those were risks. From there were then programs that needed to be put in place, like diabetes education, healthy heart, different programs that once you've identified those patients, you can work with them. One of the biggest issues that we ran into are the psychosocial issues. We really weren't as prepared for that, but that's really a big component of how successful you are in motivating those patients to take care of themselves, because a lot of this is the patient has to be involved in the decision making. And so identifying the psychosocial aspects became critical. So as we moved along the continuum with this, there were more and more data points and more areas that we had to be able to capture data from. So once we started really getting data from the health plans and using our EMR data, we were working with PSCI to be able to risk stratify that population and be able to drill down multiple layers so that we could really find out where our risks were. Whereas if it was just a diabetic, their risk was maybe not as high as somebody who had all of the other risk factors that went with it.